Thank you very much. So the title of my talk is Ultrasound-Guided Regional Anesthesia. The question is why? Now, in a survey of orthopedic surgeons done in one of the Canadian hospitals, the surgeons were asked about the good things and the bad things about regional anesthesia. The good things are obvious. The patient had less postoperative pain. And in general, there's less complications of the general anesthetic, nausea, vomiting, confusion, and medical complications. They were asked also about the bad things. And not surprisingly, they list the delay in the OR being the major disadvantage of regional anesthesia. The other disadvantage is actually unpredictable successes and perhaps complications. So there are hurdles in regional anesthesia. The hurdles are the time, the procedure time, the onset time. And then there are the problems of success rates and complications. I grouped them under the two categories of problems that we have, the 時間表 and the 路線圖 that we talked about in the last couple of weeks. Now, would ultrasound-guided regional anesthesia provide a solution? It is possible, actually. This is a recent editorial in British Journal Anesthesia. It says the ultrasound is fourth dimensional. It provides a three-dimensional map of the area, and the operator can then direct the needle towards the target nerve. The fourth dimension of time allows the operator to assess the spread of local anesthetic during injection. So ultrasound-guided regional anesthesia provides a map and a time as well. So there are some theoretical advantages, and these advantages include the use of ultrasound can be used to assess normal anatomy. So in each individual, there's no reason not to look at the anatomy anymore. So you do a scan, you will have the opportunity of doing an in vivo systematic examination that enhances anatomic understanding. The ultrasound images also can be used to supplement anatomy textbooks, cadaver dissections, and MRI studies. And the advantage in patients with difficult anatomy or different anatomy or abnormal anatomy can be very obvious. One can use a modified approach to improve success and avoid complications. The other theoretical advantage of ultrasound is that it provides real-time guidance of needle puncture, navigation, and injection. So one is able to see the needle directly and the needle tip, and then able to identify the adjacent structures to avoid injuries. And one can also observe the nerve-needle interaction and the spread of the local anesthetics. So these are the theoretical advantages, but you will ask, what's the evidence? Is ultrasound-guided regional anesthesia any easier than conventional technique? Is it faster, as the surgeon rightfully asks? Is it safer and more effective? Well, I must tell you, to study a technique is actually very difficult, especially ultrasound-guided regional anesthesia, because you can't have a placebo-guided regional anesthesia, and you cannot, double-blind anybody when you do, have techniques like this. So if you look for, the pyramid of evidence, you will not be able to find any double-blind randomized control studies. There are some randomized control studies, some case series, and quite a number of isolated case reports. So in terms of evidence, the most basic is the preliminary feasibility studies. There's actually a whole host of them. Ultrasound can be used to guide regional anesthesia in a number of different anatomic locations, ranging from the superficial brachial plexus to the deep neuroaxial block. So there's actually a whole host of references. There's no need to go through them individually. Now, in terms of randomized controlled trials, there aren't too many of them. Ultrasound is still a reasonably new technique. It's been around in the last 10, 15 years. But there are a few randomized controlled studies. One of them is the ultrasound guidance to do the 3-in-1 nerve block, the femoral nerve block. So the investigator compared ultrasound guided versus the nerve stimulator guided. And this is one of the results. So they found, using ultrasound-guided 3-in-1 nerve block, the onset, which is defined as the onset of surgical anesthesia, is defined as a 30% decrease in sensitivity, a 70% decrease in sensitivity. Using ultrasound, the onset is around 10 minutes, whereas using a nerve stimulator guided, the onset is delayed to around 20 minutes. And then at the end of the assessment period, they found that the ultrasound-guided 3-in-1 blocks are actually denser compared to the nerve stimulator guided by a magnitude of around 1 time, so 10% residual sensation versus 20% residual sensation. The similar group of investigators also look at different dosages, and they found using ultrasound-guided 3-in-1 nerve block, the dosage required actually can be reduced to 20 mils of 0.5% bupivacaine as compared to 30 mils of 0.5% bupivacaine under nerve stimulation, producing an advantage using the ultrasound-guided regional anesthesia. A more recent randomized controlled trial is on the use of ultrasound-guided supraclavicular nerve blocks. In this group of investigators study a bigger sample of patients, 40 in each group, ultrasound-guided and nerve stimulator-guided. They found, using ultrasound-guided, the time to perform the nerve block is actually shorter. So they only need around 5 minutes to do an ultrasound-guided nerve block, whereas the nerve stimulator, they need 10 minutes. Now, the success is not statistically significant, but on the whole, it shows a better outcome in the ultrasound-guided group. 80% of the patients had surgery under the block alone, and none of the patients require a general anesthesia. They only require supplementation to have the surgery completed, but it has not reached statistical significance. They also analyzed the blockade in different nerves. The significant finding is that for the ulnar nerve block, using an ultrasound-guided, which is up here, the failure rate is much lower than that of a nerve stimulator-guided supraclavicular nerve block. So the overall quality of block is better using ultrasound-guided supraclavicular nerve block because it will get the ulnar nerve more frequently. There are evidence from also case series. I selected 2 case series which highlight the development of ultrasound-guided regional anesthesia. They are both done on infraclavicular nerve blocks. Now, the first series is 60 patients. It's actually done by a Japanese group. They do 2 injections, 1 medial, 1 lateral to the subclavian artery, total of 30 mil, producing a circumferential spread of local anesthetics around the subclavian artery, so-called a donut sign. For using this technique, they were able to achieve 95% surgical anesthesia in patients undergoing arm and forearm surgery, and there were no major complications apart from 3 patients having paresthesia during the procedure. Following that, there was a bigger study published more recently. In this study, in this series, they studied 126 patients. They modified the technique slightly because the improvement in technology, they were able to identify all 3 cords of the brachial plexus at the infraclavicular fossa. So they injected around each cord, and they did total 3 injections. With the improvement in ultrasound images, they're able to test the injectate to see the spread of the local anesthetic around the cord before they inject the bigger dose of 7 to 11 mils. So the time to perform the block was 10 minutes, and the onset is actually a lot quicker. Most patients had a complete onset actually in less than 10 minutes. 90% of the patients had surgery without general anesthesia or supplementation, and in 53 of their patients, they actually put in a catheter for continuous nerve block. And complication, there's only 1 patient had blood aspirated from the needle, and 3 patients had paresthesia during the procedure, and there were no other major problems like pneumothorax and so on. Apart from the case series and the randomized control trial, there's actually some more of this anecdotal observation. They are not very strong scientific evidence, but they actually make sense, and they actually contribute a lot to the understanding of regional anesthesia. First of all, it's the use of direct visualization of local anesthetic injections. With improved ultrasound images, one can actually see the spread of local anesthetic, so-called the donut sign. This is the original description surrounding the subclavian artery. Nowadays, when people inject local anesthetic under ultrasound guidance, they prefer to see a circumferential spread of the local anesthetic around the nerve that tend to produce a higher success rate. And using this technique, one can individualize the local anesthetic dosages. In some patients, you can increase the dosage if you worry about the spread of the local anesthetic. In some patients, you can actually decrease the local anesthetic requirements. Now, the direct observation of injection of local anesthetic also useful in preventing complications. So you can detect intravascular injection, and there's also more recent report of detecting accidental intraneuronal injections. So one of the major concerns of doing regional anesthesia in the anesthetized patient is the accidental intraneuronal injection without the patient alerting you to the problems. So if one can reliably detect this complication under ultrasound-guided regional anesthesia, perhaps one day it will be possible to do nerve blocks in anesthetized patients again. The other important recent observation is actually provides a better understanding on some of the problems associated with nerve stimulation. In some patients, regardless of how hard you poke, you never be able to get a nerve evoke responses. There actually can be a number of reasons for it. So, during the ultrasound images, there are a lot of observation of lack of evoke motor responses despite needle nerve contact on ultrasound. So there are questions about whether nerve stimulator is actually delivering the current that's shown on the monitor. Whether it's because the stimulus duration is too short, whether the patient has peripheral neuropathy, and whether there's a problem of this so-called preferential channeling of the current. Apparently, when you touch a nerve, the conducting, the connective tissue actually provide a better conducting property as compared to the nerve vesicles. And some of this might explain why the needle touching a nerve and there's no motor evoke responses. Okay, so that's some of the evidence that I could find in the literature. So if we're going to produce a nice report on the use of ultrasound locating devices for peripheral nerve blocks, what do we say? I think there's evidence it's faster, it's more effective, it's safer, especially in the short term. The long term, nobody would know, and perhaps it will never be able to prove whether it will reduce the incidence of residual nerve deficit after regional anesthesia. It will take years and thousands of cases to prove. Any easier, we don't know. Perhaps you will make the judgment after the session today. In the development of regional anesthesia, there's always some debates going on. Back in the 40s, there's debates about the existence of fascial compartment. Later, there's debate about the use of paresthesia and the disadvantage of paresthesia. And there's discussion about the use of single injection versus multiple injections. The more recent debate is whether regional anesthesia is an art or a science. The obvious implication is using ultrasound, one can see what's happening and provide better scientific evidence that would guide the development of regional anesthesia. So back to the question, ultrasound-guided regional anesthesia, why? I promised Dr. CUHK I have invited Donald here today. He will tell us it's the 路線圖 and the 時間表. So remember these two important phases that will come up every now and then in the next couple of years, associated with ultrasound-guided regional anesthesia. Now, it comes to my last slide. This is also I think, the more important slide. Now, if we don't do ultrasound-guided regional anesthesia, what will happen? So why not? Why not? I promised to ask SK a question. So what's the question? If we don't do ultrasound-guided regional anesthesia? Thank you, SK. Thank you very much.